Welcome to the 2017 Healthcare Providers Transformation Assembly. My name is Nick Peacock-Smith, and on behalf of the entire Millennium Alliance, we thank you for joining us and welcome you for a couple of fantastic days to talk about healthcare. And I'll have a couple of quick announcements at the end of this panel, but I want to turn over to this exceptional panel for the conversation to really kick off the entire assembly. And it's my pleasure to introduce Bill Spooner, a HRT advisor with Next Wave Health Advisors. And please join me in welcoming Bill and this afternoon's fantastic panel.
Thank you, Nick, and good afternoon. Again, I'm Bill Spooner. I'm a mostly retired former CIO. I was with a System Sharp Healthcare in San Diego for 35 years until I decided to take a more relaxed approach to life, so I'm doing a little bit of advisory work around the country. But it's a pleasure to be here and to introduce this topic. The topic title is Consumerism and Meaningful Technology Engagement. And obviously that conversation can go anywhere, and it's really dependent upon these four panelists that I have with me. I have a handful of questions that I'm going to ask each of them, and and at the end we'll take the last 10 or 15 minutes to take questions from the group, because I'm sure that there are lots of thoughts that will come out of the audience as well. So why don't we just get started, and we'll just start from right to left, a brief introduction of yourself and your organization, and maybe how consumerism is embodied within your organization.
I'm Ivan Durbach, CIO, Bronx Lebanon Hospital. We're two hospitals in the Bronx, south and central part of the Bronx, one of the poorest congressional districts in the country, and we're now going through, and just to give you an idea, patient engagement is very important to us because we're going through, amongst other things, DSRIP. All of our Medicaid patients, we're 60% Medicaid, we have to show that, and in 2020, right, 2.5 years, wow. So that's 2020, we have to show a 25% reduction in inpatient and ER avoidable visits. So we're gotten into this whole process of outreach. Everywhere you go, outreach, community health workers. And what better way to outreach to our patients than through electronic means? So that's why it's one of several reasons why patient engagement is very important for us.
Hi, everyone. I'm Ashish Atreja. I'm a practicing physician, and I'm a Chief Innovation and Engagement Officer in medicine at Mount Sinai Health System. I direct the App Lab, which is the in-house innovation lab at Mount Sinai Health System, which is also in New York City. And we have 7 hospitals, 7,000 physicians, 2,000 training physicians within our health system. And it's very unique where we are positioned. We are right at the cusp of border of Upper East Side and Spanish Harlem. Upper East Side being one of the most wealthiest area within New York City, and Spanish Harlem has 40% poverty rate. So for us, patient engagement means, what does it mean for our underserved population, where patient engagement is social determinants of health, access to care, and those kind of things, versus this Upper East Side population, where it's all about quantified self and kind of Internet of Things and those kind of stuff. So we are trying to address for both populations, and not only alone, but also in partnership with other health systems. And we'll talk more about what does patient engagement mean? What is the metric of success when you can say you have met patient engagement? Or is there a metric of success? There are many more unanswered questions which we'd like to surface and have a discussion around. Thank you.
My name's Michael Malcolm Ovitz. I'm a Senior Vice President and Chief Clinical Integration and Network Development Officer at New York Presbyterian. I was brought to New York as part of New York Presbyterian's decision to regionalize, when previously it had not regionalized, and now over the last 3 years, we've regionalized with an additional 4 hospitals, a new medical group, and what makes New York Presbyterian a little different is that it has 2 medical schools affiliated with it, Columbia and Cornell. Each has its own physician organization, each has its own medical school, and now there's a 3rd physician organization which I set up called the New York Presbyterian Medical Group, related to the regional expansion of the organization. So clearly, when we're talking about patient engagement, we're talking about patient engagement across 3 physician organizations, multiple hospitals, including the largest academic medical center in the country. I would say that patient engagement for us relates to patient engagement when they're in hospital, at receiving every kind of care that's available, obviously very complex care as well, patient engagement with their physicians in the different environments, and patient engagements in the context of getting access to healthcare with, remotely, because it's just too difficult and we don't have the space to see people in a facility at all times. So we can talk a little bit about the new digital approaches through a single application that patients can use and the patients and consumers can use to access a variety of services. And I think this has been the most recent element of engagement and trying to centralize it and create a single portal of focus for all these components that I mentioned.
Good afternoon. My name is Peter Kung. I am the System VP of Innovation Virtual Health for SCL Health. SCL Health is a $2.5 billion revenue health system based out of Denver, Broomfield's a couple miles out, but we operate in the states of Colorado and Montana. And what I do in the health system is I identify, initiate, and deploy high-value ventures that increase access and improve patient experience. Particularly, the initiatives that I'd be looking at within those two broad spectrums are find a patient and keep a patient strategies. Before I came to SCL, I landed there 2.5 years ago. I was at UCLA Health for 13 years with appointments both on the research side and the hospital side, in which I reported to the Chief Innovation Officer and Chief Operating Officer. And I think one of the things when moving into SCL Health is, what does innovation mean when we're zoning in on access and experience? Because before, when innovation centers around the nation started popping up, it was somewhat unfocused, and we're going to see a lot more focus in terms of innovation, digital transfer, and consumerism. Because if you take the large spectrum of primary, secondary, tertiary, quaternary care, for the academic medical centers, it makes a lot of sense for tech transfer, commercialization, patenting, because of the research arm, or your large health system like a Providence or a Trinity, where you can pull out of that. SCL is more in the community health system, where it's a little smaller, a little more niche, and what we're going to be concentrating on is improving access and experience that's 10 times better than our next competitive mate.
So I'll start on your end of the room, Peter.
Sure.
So is the technology coming first, or is the innovation coming first? And what's the role of the patient in the middle of it?
Yeah, so a couple of things. We were talking about this a little before. I said the only thing that's moving faster than the pace of technology is consumer expectation. So I think that's the first thing. Where the second would be, in terms of my health, who cares more about my health? It's not my care team. It's myself and my family members. They care more, right? And I think where you're seeing the empowerment of mobile and all these different things going on is the empowerment for them. And also the economic incentives, whether that be high deductible plans and things like that, that are going to drive that. We also have other folks like Apple wanting to buy over one medical group and all these things, where the fact that these people, we get a choice right now as a health system, is we get to choose to disrupt ourselves, or someone else is going to do it for us. Right? And we do see a lot of, I wouldn't call them startups anymore, not two kids in a garage, but very well-established companies out there that are really attacking some of the things that we're not really good at, because as health systems, we try to become all things to all people, and their focus, these companies, day in, day out, they raise 50 to 100 million to solve that one problem. And so I think there's a couple of things going along with it, whether that be what's moving faster. I say the consumer being empowered because they want to take care of their own health.
So for the purpose of this discussion, I see us using consumer and patient fairly interchangeably. Is that really the case? I always view the consumer as everybody I'm trying to attract into my system, and the patients are the ones that I win. But as I hear the descriptions, it sounds like there's a real blending of the two.
I think all discussions about patient engagement have to start with the fundamental assumption, the 30,000, that we're talking about a consumer, as Peter so eloquently put it, who's, should be, if not directly responsible, empowered, we've heard the term. There's a term that came out of one of the recent sessions, each patient should be their CMO, Chief Medical Officer of their own health care. So that's the fundamental. So then how do we accomplish this with, to a large degree, technology? And so, now we look at, how do people use technology around them? I mean, not that many of us go to banks anymore, do we, here? So, think of that whole process that has happened, amongst all parts of our society. Surely we can bring technology to bear to help in something as fundamental, as important as healthcare.
I think that Peter alluded to the fact that what's causing this discussion is the fact that there's been a massive change in healthcare in the United States. The ACA was introduced. The ACA is being either chipped away at or it's actually working in some places. And the result of that, plus the cost of healthcare in the country, is putting pressure on providers. Pressure on providers, whether they be hospitals or doctors, gets trickled down to patients who have to pay more out of pocket. It's sometimes harder to get to the correct doctor at an appropriate time. And with consolidation, while there are enhancements of quality, there can be structural changes that might make this more expensive for patients who have higher deductibles. Having said that, this comes down to the notion of consumerism, where the issue of value and convenience becomes preeminent in the consumer and the patient's mind. So whether I'm looking for something related to my health or something related to my disease, the issue of convenience and value have become more and more preeminent, particularly since we have become more and more accustomed to lifestyle commodities like cell phones and Siri and Alexa and everything else. So we're starting to see a merging of these worlds. And I think that accounts for the trends that you see in many health systems. This is not any one organization that has the genius to do it uniquely. And in the case of New York Presbyterian, this notion of opening up to the consumer through a single app is a good idea. It's not my idea. In fact, not even something that I did. But it's called NYP On Demand, and you can go and see it. And the consumer can go to this single app, and from that location, they can get a second opinion. They can get an urgent care visit. They can get a face-to-face with a doctor of their choice, actually in one of the three groups. This single app is also a wayfinder. You can pay your bill for any of the organizations. You can see your medical records for any of the organizations. So not that any of this is that remarkable, but it's remarkable in the sense that it happened so quickly, and that I think we're all going into those areas of convenience and value, in terms of having both patients who are sick and consumers who are looking for help.
I would completely agree with that. I think the major fundamental shift we have seen is just by using the word consumerism, you stop taking patients for granted. You go with the concept that they are gonna chase other doctors, other health systems, if you don't provide a value, whatever they do. And I'll share a personal experience. I practice IBD, so one of my patients used to drive 4 hours to come from upstate New York, and she was pregnant and I had to see her, but it snowed very heavily. This was before New York State passed the parity law for telemedicine. So I said, fine, I wouldn't get paid, but I need to see her. So I opened her telemedicine box, I saw her. By the end of the encounter, she had tears in her eyes. I said, what happened? She said, Doc, I never told you. Just coming to see you used to take me 10 hours, a whole day. 4 hours of driving, 1 hour of finding parking, 1 hour of going back to find the parking, and then going out for 4 hours. And it seemed you were able to provide exactly the same care, and I was able to save the whole day. And plus, I was so worried about me driving in the snow with me being pregnant because I'm a high-risk pregnant patient. I did not get any money for that. Suppose there's a parity law, I would have got the same money. The patient suddenly got so much value. Now she said she's going to specially look for an IBD doctor who only provides telemedicine care or mostly provides. She had 3 more telemedicine visits with me, not a single office visit, right? And I think that's completely changing the game. She's now become a consumer. I know that if I stop offering her that convenience, she will find someone else in that regard. And I think this is a fundamental change we as physicians have gone through as well.
So talk about that a little bit further. How broadly is that grown inside your organization? Is telemedicine something that is still an occasional point solution, or are you getting a big adoption of it? Are your patients really looking for it?
I know NYP has done a lot more with telemedicine. I'll just start off with one thing. We don't believe telemedicine is about technology anymore. Technology has been validated. Telemedicine is all about use cases. Is actually the onus of telemedicine getting an ROI is not on the technology company, which we partner with. It's actually on our health system, whether we use telemedicine for readmission reduction, where it has shown so much value, or for on-demand care, which NYP has been doing fundamental stuff. So I think it's all about use cases, how you use it to create value. We just signed a big contract, so we started telemedicine journey around 1.5 years later than NYP. But we're learning a lot from seeing NYP, how use cases are being built. So that's our general take on telemedicine.
So there are people who've been doing telemedicine for years. And in fact, telemedicine in its early iterations failed. And the reason for this is that there was insufficient adoption and the technology probably wasn't mature enough. So I think we should differentiate between, I think, what's generally accepted as telemedicine and telehealth. So generally speaking, in the literature, when they talk about telemedicine, we're talking about interactions between doctors and patients, the kind that you were talking about. Telehealth is broader, and telehealth would be anything related to using a technological medium for wellness or healthcare, or combinations thereof, where this is all going. So, for example, one of the features that a few organizations do have is a stroke mobile. I know the Cleveland Clinic had one, and NYP has a few of them. And so somebody could call up with an emergency with a symptom that sounds like a stroke. So instead of dispatching an ambulance to bring you to the emergency room, you dispatch a stroke mobile that has a CT scan. It has the ability to provide infusions. It's got a hookup to a stroke neurologist back home. They do the scan. They see if it's a hemorrhage or if it's an obstruction. If it's an obstruction, because they can see the CT scan, they start the infusions immediately in the ambulance. So that's telehealth. Cases from nursing homes, for example, that are requesting transfer to a hospital can be evaluated through telemedicine, involving the nurse, the respiratory therapist, whoever else is taking care of them, and a decision can be taken in a more in a telehealth concept, not to transfer the patient or to transfer the patient. So the answer to your question about adoption is that, and that's why I started with the definitions, is that people use the words in very general terms. So the head of one very, very large organization said that 50% of their patient interactions, Kaiser, was through telehealth. Now, that's well and good, but that includes phone calls, portal access, smoke signals. I'm teasing. I think that on the specific use of telemedicine from doctors' offices to evaluate patients, I think adoption is still low. I don't think that the reimbursement issues have been worked out. I don't think that there are core competencies that have been generally accepted, and we haven't had enough training of enough physicians to be comfortable to do this in any mass manner yet. But I think we're on the verge of that, and I think we're going to see much more work in the area of core competencies, use cases, scope of care. I know that I personally spend a lot of time on use cases, and this becomes a very interesting scenario when you can explain to a physician about a use case for a particular condition. So people used to think of telemedicine for coughs and colds and rashes. You know, that's really old hat. It's not a big deal anymore. But say, for example, this is a real life case. A pregnant woman who was a teacher needed an ultrasound with a focus on the fetal heart for a possible fetal heart cardiac abnormality. The person was being seen in a borough by the doctor, so had to go to the mother house because they wanted that particular maternal fetal expert on cardiac abnormalities to be involved in the case. So the test was done, you know, at the mother house. The mom had the test and went back to work. Then you needed a follow-up visit to discuss the test. Discussing these tests is not a simple thing. You've got to show where everything is and where there's this, where there's that. The husband who works somewhere else, he also wants to be in on the action. So you have a telehealth visit. You can get the husband on the same telehealth visit. You can show the test results, and you can point out what the issues are, and mom didn't have to take another day off work. Hubby could be on the call, and there's a real feeling of engagement. So that's a complex example of a use case, but you can go on and on in bariatric medicine, in adolescent medicine. So I think people are working much harder at doing what you're talking about in finding use cases. I think the insurance and payment issues will get better. I think the core competency issues will get better. I think training of doctors will evolve, and I think this horse left the barn.
What are you seeing in Colorado?
So that's, with the definitional, that's why we raised it above. We just called it virtual health, almost like the same tactic that MGH calls it connected health that looks across the board. The thesis I have would be, as we're moving to value-based care, or say capitation, these are the tools, digital health, virtual health, whatever you want to call it, will thrive more and more because you're moving your care outside your four walls. Now, if you imagine Montana, they just have been historically there. I mean, there's 1 million people across the entire big state. So historically, we had many service lines going. We've also did the cold and cough thing, and we partnered with Doctor in Demand. And if you look at for our self-insured associate medical plan, our first year was 10% utilization. That was big, right? And so if you look at from the capitated side, you could see the right care at the right place. It has economic benefit. And you're starting to see that with just consumers in general. They're willing, when it comes to these cold and coughs, it's not the brand name per se. I think the overriding one is access and convenience. That's what they want. You could put any name on top of it, but if you just know you have hay fever or pink eye, you don't have to go to the #1 in the nation for that, right? So there are certain things. But going into, if we start moving to more of the value-based capitated model that pushes our care outside, I think you're going to see much more adoption. Now, where you do see adoption a lot with more of, like, say, I'm just going to use the AMCs, is the specialty visits. And the one that from my previous past, that one that was always like, all the specialists just sign me up, is post-surgical follow-up visits under the global period. When's the OR, their surgeon, whoever liked clinic days, one. So you could say, I could cut clinic days, and two things. You could be where you want, which is the OR, or two, potentially schedule a new surgical case. So I think you're going to see a lot of different plays depending on the business model and the strengths of your health system.
We have at Bronx Lebanon Hospital a major use case of telemedicine, telehealth. in our ERs. Think about it. Every day, we have hundreds and hundreds of patients come in from the South Bronx. The mayhem of the South Bronx come in, and then gang wars, everything else going on. Many of these patients come into a medical ER that have behavioral health problems. They're bipolar, there are other things. So we need these psychiatric, these behavioral health specialists. So we've been using for several years telemedicine, where we reach out and have these behavioral health specialists come in on these medical emergency patients. And it's been fairly successful for us. So these use cases are going to drive us to use telemedicine, telehealth much more in the future.
Yeah, I just wanted to say one thing. I'd be remiss if I didn't make a comment on behalf of my good friend, Dr. Rahul Sharma, who is the emergency medicine in chief for New York Presbyterian. I've got to give him a plug because he was in the Wall Street Journal and all over the place, having introduced telemedicine access in the emergency room at Weill Cornell. And this got a lot of publicity, and it was published in the New England Journal Catalyst. And so Rahul had this great idea that if you came into the Weill Cornell emergency room at 68th Street, which is always busy, you can go to a fast track, which is an urgent care. And then, probably about 7-8 months ago, they put together if once you were triaged, you could go, and you were of low complexity or low intensity, you could go to the urgent care track and wait to be seen by a doctor, or you could go to that comfortable looking living room and see a virtual doctor who is somewhere else. And this has reduced the wait for the urgent care patients to like 29 minutes. It's really a great success. We're putting it into our other emergency rooms as well, and it's being adopted by other people. So this is again, an example of convenience and value, that you don't have to put up with what normally goes on in a busy emergency room. So I couldn't resist but.
And are you being paid for those visits?
Sorry?
Are you being paid for those
visits? We are being paid.
So just to recapitulate, I think 4 of us are here, and we all have different use cases, how we're using it. Pop health, to ER access, to chronic disease management, to behavioral access. And I think that's what we have found in telemedicine. It's a platform, and you see in your health system, in your healthcare, what makes the most business alignment, and use it. So my only urge to you is not to invest in a one-off point-and-click telemedicine solution, but actually invest in telemedicine as a platform, so you can drive multiple use cases of it for multiple ROI.
So looking at this in the overall context of patient engagement, in what way does this fit into the formal strategy of the organization? Is it part of your strategic plan, and who owns it? How do you make it happen?
At Bronx Lebanon, it's part of our 3 major strategic initiatives to patient engagement through electronic means. I mentioned already the district, very important. All these thousands of outreach processes happening every day. Why not electronically? Second issue, we still got meaningful use on our necks, right? So we're still chasing after the doctors for the $8,000 a year, meaningful use, 5% patient portal, right? Yeah. And the third issue is that we're learning that, especially for chronic management patients, it's really from a patient quality point of view, it's the right thing to do. The old days when a patient used to come in and see a doctor every 3 or 4 months, doctor would go off regimens for everything, prescriptions and exercise and nutrition. He'd come back in 4 months. Well, that doesn't work that well anymore, especially as we move towards value-based payments, capitation, in the onset of district. So we see this as, frankly, fundamental to our future survival.
In our, we had a 5-year strategy we proposed last year, and we had 5 petals, what we call as Digital Daisy. And in the Digital Daisy, we had, some people like the name Digital Daisy. It has, one of them aspect is telemedicine. The other aspect is optimizing the EHR. And the third is apps and wearable devices and IoT. The fourth is AI machine learning. And a fifth, we labeled it as just innovation, which we don't even know is going to happen. Maybe blockchain or what have you, and we need to have a kind of a finger on the pulse of latest disruptive technology. We can't even imagine what will be there. And these are all baked into our digital strategy. So any new startups we try to engage with, or any new initiative we say, does it fall into any one of those 5 petals, but those all 5 petals have also organizational units supporting them. So we can actually manage that innovation cycle through that.
Telehealth is a major initiative for the organization, directed from this office of the CEO through an innovation center and information technology and all the provider units. So there is no question about whether this is a priority, and it's designed to meet the needs of the patients. The hospitals are generally full, and there's a desire to get patients out of hospitals sooner so that other people can get access. Slightly different issues facing us. And because I think of a shortage of primary care doctors in general in New York, the notion of using telehealth to provide access for patients for conditions that are not that serious is another important element. And because of the complexity of the tertiary and quaternary programs, particularly in cardiovascular and neuroscience and cancer and rheumatology that are going on, the notion of chronic disease management and trying to make the life of the patient simpler and more convenient through telemedicine is an integral part of the strategic growth of the organization and its regionalization.
So at SCL Health, the primary strategic goal is what we call person-centered care, and then all the growth initiatives underneath that support it. And in my role, I get to play with technology, but it doesn't always have to be technology. And going to your story about the driving, when we look at the social determinants of health in terms of transportation, behavioral health, and just socioeconomic standards, sometimes getting to and from care is the simplest thing, but it's needed. So, we struck a partnership with Lyft to be able to do that transportation for those non-urgent cases. At the same time, when I look at digital, when it comes to tech, I think we have to separate, in my work, digitization and digital transformation. And what I mean by that is I'm working on one. It's a simple concept. Bear with me. But I think it addresses one of the big patient disappointments or pain points is I want to get rid of the clipboards. Okay? Very simple concept. I don't want to ask you your name twice or 3 times or 100 times, same medications, allergies, things like that, right? So let's get rid of the clipboards. But from the operational side, whatever we're going to bring in also needs to be able to re-engineer our processes, so let's take the ambulatory side, in a way that I destroy the waiting room. Now, how do we do that? Because if all I did was take a paper clip and I put it on, say, a kiosk, all I just created was a more expensive clipboard, right? And so when we take a look at when my team takes a look at technology, say clipboards, we're looking at, 1, let's get rid of the clipboards, but 2, true digital transformation would be, let's blow up our waiting room so there is maybe the patient could room themselves, or we could say, hi, we've been expecting you, come in here. Why don't we also do this? You have a 1:30 appointment, but we always say come at 1:15, and they know what we're doing. So let's make that let's smooth the entire and re-engineer that process in a way that we're talking about true transformation rather than digitization.
And if you look at the literature, there's one school of thought that will describe digital health. It's just as you have. It's transformation. If it isn't transforming healthcare, then it really isn't digital health. Then there's the other side of it that says it's gadgets and smart and mobile apps and consumer wearable devices and so forth. What's the blend in your organizations of the demand for both?
We're just starting to scratch the surface, both organization and I think in many hospitals around the country, in starting to engage the patient more through their cell phone and their apps. I think it was you, Ashish, taught me there's 225,000 healthcare apps across all of our different cell phones, the iPhones, the Androids, right? And how many of those actually talk to our doctors and nurses? Virtually none. So that's a very startling fact. So why not? And we've talked about it a lot. Too much data. We need filtering. We need this. But this thing is coming because our consumers, let's call them our consumers, they're used to using these apps in all their other lines of activity. They've stopped going to banks. many of these items. So healthcare has to be next in line in order to take advantage of that.
And we at Sana have this, we call it FIT initiative, from innovation to transformation. And we have agreed on a two-speed IT as an example. This was proposed by Gartner many years ago, where you have the mothership, which is the main IT, which is kind of keeping the lights on, but also security and all those kind of stuff, and EHR implementation, all kind of stuff. But then you need a very nimble speedboat. It doesn't have to be very big, 10, 15 people, 5 people. Sometimes it starts with one person who is kind of look out of the new technologies which are aligned with that, and then provide a feedback to the mothership. Hey, go in this direction versus that direction. Is telemedicine the right thing to adopt versus IoT versus others? And then we feel we have a very big funnel of what we call as let the multiple flowers bloom, let the 1,000 flowers bloom, which means we have pockets. We are testing IoT, genomics, precision medicine, and all kind of stuff, AI, virtual reality. And then as we have, but all of them have standard metrics. It's very important to have a standardized metrics, because at the end of that pilot, you want to say this was successful or not, right? And many times we can't even call it. We say, oh yeah, there was a good engagement, and this was a nice technology, let's adopt it. But we don't try to do any pilot unless until we know what it is, a metric which will make it successful. And if it is successful, we will adopt this mainstream into our health system. If we can't say that if this metric is met and we'll adopt it into our health system, then means we're just playing with the technology, wasting our time and wasting the startup time. So we see it as a continuum from innovation to transformation. And where we feel telemedicine is at the transformation angle, where it's not about innovating what the use case. We know the use cases, we're just gonna make it available to everyone. We also see remote monitoring, which is kind of tied with the telehealth concept, which is either app-based remote monitoring or device-based or IoT-based remote monitoring, becoming mainstream because there's a business model around it for CCM, chronic care management, and pop health efforts. So these two and secure messaging, we feel have gone to the transformation stage. Many things like augmented reality, virtual reality, blockchain still is at the innovation fringe. We haven't figured it out when and how to make the journey for transformation.
I think there's an awful lot of work going on between, in innovation within the broader institution. If you just think of this Columbia, there's Cornell, there's now Cornell Tech on Roosevelt Island, and there's NYP going about its business. So there's a wealth of activity going on a basic level and from a commercialization level. I think the organization has announced that it's also involved has a small investment arm now that is involved in new technologies. It has an office in Palo Alto. And I think what you're going to see is what you're seeing through, for example, NYP on Demand is an attempt to centralize and coordinate all the digital health functions through one portal throughout the organization, including some of our new service lines. So while yes, there are people interested in artificial intelligence and virtual reality and everything else, I think right now our focus is on streamlining this for the consumer and for the providers in one place. And yes, on an ongoing basis, looking at additions to that core of activity and incrementally adding to it and standardizing it across the entire enterprise.
And just by the way, I think it's a brilliant strategy that the NYPD app, where there's no disintermediate in terms of getting the relationship between the health system and the patient. So you're not moving them to Epic MyChart, you're going to move them to My NYP or NYP on demand. I think that's a brilliant strategy. When it comes to innovation and consumerism, the fun part about it in the innovation world is you're legal's best friend, right? It's always in the gray areas. You're trying to push the boundaries. It's going to be different from the core of the organization. Yet the idea is purely, the other flip side of innovation is just pure ops, where what you're trying to really do is take that bright, shiny toy and make it the standard delivery of care. That's what, when it's so dull that it becomes the standard delivery of care, that's when innovation wins. Like, yes, it worked. And going how SEL works within innovation, we use the concept of, there's high uncertainty and low investment, and those two lines will cross at one point, where if you want low uncertainty, you're going to have great investment in it. Let me give you an example. That those two principles are mutually exclusive. It's just like saying, I want an IKEA-priced solid gold table. You're not going to ever get that. Those principles. So if I said, what's going to happen in value-based care over here, you could give me an example: high uncertainty, low investment, a couple of brain calories, right? And so how we move and iterate in coordination with the mothership core of the organization is we get to iterate as much as we want. Let us go. You don't have to put the whole 9 yards on us. You probably have all your processes. Let it go, and that's blessed from the office of the president for us. When we go to market, that's when low uncertainty and high investment, that's when we're going to be very sure. It's almost like saying the Samsung exploding phone, right? When they went to market, that $2 billion investment, and they should have made sure that battery didn't explode. But before that, is the battery why you bought a phone? Maybe, but it's not probably the top of your mind. What you want to get to is what's driving value for the consumer. And so that's the way that at SEL, how we move, iterate, we'll explore new ways of doing things.
So just to change the focus a little bit, as we are all implementing or making the case to buy our EHR products, our solutions, we put together an ROI case, and we all pledged our lives that that there really was an ROI, and I can't find anybody today who actually can prove that they got it or that believes that there ever was one. Now, I'm going to turn to a paper that came out just in the last week or two from the company formerly known as IMS Quintiles. I forget what their new name is, but basically they said that over 5 disease states, digital health can realize a positive net gain of something like $7 billion a year, and if they extend it over a number of other disease states, it's $56 billion a year. So do we believe it? Is there an ROI on digital health, and why is that different than what we've done to date that we don't think really has returned the investment?
Well, if I can just take a quick stab at that, 5-10 years ago, we sometimes debated with our CFOs the interesting question. Only 5-7 years ago, what is the ROI of an electronic medical record? We had to prove that sometimes. Remember some of those discussions we had back 10 years? Well, nobody asks that question anymore. So similarly, in the case when you have to reach out to your patients, you have to have care coordination, especially for the CCM patients, as Hughes pointed out. When you have value-based paying, like this rip coming down on necks, there's no question that this has to happen, And nobody's going to question and demand that you document exactly precisely. You talk about various strategies in order to make it less or more painful, but it's definitely that it's there, it's coming there, is being driven by the consumer, who's using their smartphones for virtually all of their day-to-day processing across so many other verticals. Why not healthcare?
I couldn't agree more with Awan. And the question is not why anymore, why to use digital medicine. The question really in front of all of us is how to use digital medicine to make the maximum business alignment for us. And I think that's a question that we have to solve looking at our organization structure, looking at how much at-risk population we have, and what our strategic goals are, and then aligning it. And there's a lot of learning we have to do to kind of be able to optimize these technologies, right? So I think it's all about, and we've started seeing phenomenal ROI. If we just published data on remote monitoring for heart failure, readmission reduction, 40% improvement, right? Can we scale it? This was a wearable devices we integrate with the app. We probably cannot bring wearable device to everyone, but maybe we can use a AI-based or a text messaging platform or an app-based platform for majority of the people. So it's up to us, but it's not going to be achieved over 1 year, over 2 years, over 3 years. You have to fundamentally believe you're not doing for macro or MIPS. You're not doing for one value-based incentive. You have to fundamentally believe this is the right thing to do that will allow you to have a longer kind of a scope of horizon. So you will give that time and the direction, and then you will only keep on getting wiser in that direction.
So the question is, I think we need to discuss the hope and the facts. The facts don't bear out at the moment that we're going to save money. We don't know if we're talking about digital health per se.
Can I just interrupt?
So
It depends on how we define
let
we.
me finish. So the studies that have been published, there's a study in Health Affairs that appeared this year, in the last 6 months. So if you're talking about a real study, that's one real study, quite detailed, and they weren't able to demonstrate, looking at the literature and looking at the statistics available currently on cost, that telemedicine, in fact, they thought that there was a risk that telemedicine would actually increase the cost because of increased utilization. That would go back to the ROI, but, so depending on which side of the fence you'd be sitting, you'd say, oh, that's not such a bad idea. You're increasing utilization because you're finding out all these bad things that people have. There are studies. There's one study on preventing nursing home admissions to hospitals with telemedicine that does show statistically a reduction in cost. Okay, but I think on heart failure, something we've looked at. You'll agree that there's many conflicting studies. Studies have been done for years on heart failure programs, and it's been very difficult to show a difference in outcome, even though the patients may feel good about the contact. It's been extremely difficult to show, differences in outcome, certainly not in survival or anything like that. So, having said all that, which always makes us all uncomfortable, I think that go back to the consumer, go back to convenience, okay, go back to management of a condition, and then doing more studies to see really, if you can reduce the cost of care, or if you're not trying to reduce the cost of care, if you can make more money. But at the moment, it's about convenience for the consumer, because the consumer is used to using these lifestyle technologies in every aspect of their lives.
So I want to bridge a couple of these conversation streams. When it comes to Epic, right, we were talking about scribes before, right, the scribing. I said, it's only, in most industry, when technology hit the industry, it drove efficiencies and things like that. It's only in healthcare that what we would do is put the EHR and then we're like, oh, let's put some scribes on top, human labor on top. So I think we're still early days in it. That being said, I think there's a lot of pain points to look at the ROI because our physicians are beating their head against the wall the entire time. When it comes to digital health and things like this, I think you're right. Where we are is fairly nascent as well. The CHF study that was published in JAMA in 2016 with the 5 academic medical centers in California, he was my clinical partner, the principal investigator on that. And what was interesting is you can't just throw it out there and think it's going to work, right? And we were cohorted with the CHF, colorectal, COPD, late-stage liver disease. I think when we're looking at remote monitoring, things like that right now, to me, if I had to place a bet which team is going to work, to me, it goes down to what clinical team cares more that would react, that would engage that patient and bring them back in when there is, just right now, an alert of a blood pressure or weight over 2 pounds overnight, that kind of thing. So I think we have to temper our expectation of digital health to be like a silver bullet. I think where we're at is complementary or augmentation to our clinical teams, and at the same time, we got to do that well before do the same mistake of putting an EHR and then put humans on top. That won't work either.
And I couldn't agree with you more, Michael. So one of the things was, I would say that we still don't have ROI for annual health examinations, right? We do it all the time, right? So I think it's all about how. And I will take the same examples for heart failure. So Joe Cavadar's study was positive. It showed a readmission reduction. Because telemedicine is all about use cases. Let's come back to that. Meta-analysis, not just one study, meta-analysis have shown 30% reduction in readmission rate if you use telemedicine the day after and 7 days after the patient is discharged, right? So in that use case, telemedicine has been useful across multiple studies. But telemedicine has not been found to be cost-effective in outpatient routine care, because physicians will convert their their telephone, which was not built, to telemedicine counter. So again, I think the challenge of creating ROI is upon us to find the relevant. It's not about technology creating ROI. It's about which use cases we're using the technology to create a ROI. And the ROI, we also have to say, is it ROI for us? Or like cost effectiveness studies, you do the cost effectiveness study from a societal perspective, from a consumer perspective, or a cost effectiveness from a physician perspective. If we all become payers, which we are transitioning to, a payer will find a ROI of patient not coming, not having to spend a day just on clinical visit, and they will monetize that. But that ROI is not touching us if we just look from a physician perspective. So I think there are layers of ROI which we have to go before we answer it is working or not.
Someone suggested that we ask the question as well about the impact of digital health on quality. And from what everyone has been describing this afternoon, it sounds like we all believe that digital health can and will improve the quality of the care and improve the service we provide. Are there any dissenters?
If we do it the right way.
If we do it the right way.
It's the same thing with EMR. If we don't implement the EMR the right way, we're not going to get value. If we don't implement digital medicine the right way, we're not going to get the value.
On the quality issue, there's actually a very direct monetary benefit, immediate ROI, with these capitated companies, and we use some in New York that they're familiar with, that if we can bump up our HEDIS score scores with these risk factors and these quality indicators, we get a couple extra $1 million. So, and now how to reach the patient to bring in, haven't had a mammo in a long time, a colonoscopy, that's another question. And is the right way just pick up a phone, call them, or send them a text message, or get them to log in. So we can debate about the tactics to be used, but there's no question that patient engagement pays us directly, and I think most clinicians would say, it's bound to improve quality if the patient is devoting more time and energy to taking care of consumers' health.
Great conversation. We've run a little bit long, but let's see if we have some questions from the audience so that we don't miss that.
Thank you very much.
Hang on for the microphone.
Thank you very much for the informative session. I think, with regards to consumerism and what we've been increasingly realizing in the industry is the importance of transforming the omni experience, if you will, and creating these engagement-enabling environments of sorts. But where it becomes a challenge, at least in my experience, is around the kind of conceptualization. How do we approach this strategically? In your discussion, you made a mention to convenience. You made a mention to customers versus consumers versus patients. And we look to marketing and business management theory in the language and the approach that we're bringing into healthcare. And if we look at marketing, for example, Marketing 101 tells us that the customer is always right, the customer is king, whereas in healthcare, the patient at times may not be right and sometimes should not be right, and we need to be careful about how we create the experience. So are we pursuing the betterment of health, or are we pursuing the betterment of happiness, or is it a combination of both? What has been your observations around that?
Who wants to take that one on?
That's a tough question.
Health versus happiness.
Michael probably can.
I think to the extent that if we go back to the premise that the reason we're here is that because of the changes in healthcare and the pressures on providers and patients, there's going to be increased cost put on patients and on consumers, then consumers will be making choices based on out-of-pocket cost. To the extent that consumers get more and more used to lifestyle commodities and access to digital technologies, they're going to do the same for their healthcare. So that leads you down a road where I think you were trying to get us, was that leads you to the conclusion that people are going to be taking choices that might not necessarily be the best ones, because those decisions impact them and their pocketbook. But it's their right to take those decisions. There's no data at the moment to show that quality on a wholesale basis is improved by digital health. There's no data showing that value-based purchasing has improved quality in the United States. There's no data showing that EMRs have improved quality overall on outcomes in terms of life and death and mortality and so on and so forth, which is what really counts if you're looking at healthcare for the United States. So we need to be kind of humble about this when we talk about the promise. But that's the way I would look at that.
And just to add, I think what we can offer to patients, we can only do what our resources allow to do, right? So we never had technology to reach out to patients outside EMR, outside of face-to-face. But now we have technology, so we're doing all these engagement things, right? So we were actually talking with Deepak Chopra because he's came up with the GIO app for meditation. Now we started thinking, how do we bring happiness to our patients, irrespective of their consuming our healthcare or not? So I wouldn't say that's our ultimate goal, but it's a push and pull technology. If technology comes which can allow us to do that in a scalable manner, so why not do that? But that may not be part of business model, but it's easy to scale.
We in the South Bronx, we go by just a reliable Chevy. So forget about all that stuff, so that's all we need. But a key point that you raised was that you mentioned, marketing, a customer is always right. Say, no, 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 no. An informed customer is always right. So one thing that we've skirted the whole process is patient education. So how is the patient going to be incentivized to go to the colonoscopy or the mammos on a regular basis and use the technology, if they don't believe it? Patient education.
You're touching on a really important issue of business strategy of how you market and position yourself. We'll use watches. Why is Rolex be able to sell you 5,000 times more than a Swatch watch, right? And there's different strains of a health system. If you're Swatch, you better make sure your operations are so tight, you're squeezing out every little penny. But with the Rolex folks, they know you really well, and they provide an experience that's so exceptional, and we see that from the business marketing side. I want to get to your question about, how does SCL play in this space? And for us, it's about speed to market and getting out there. So we partner a lot. And so in the innovation space, if you just throw one enterprise initiative a year to 2 years, you're like, yay. In the past 2.5 years, we did around roughly 8 different enterprise initiatives, not including the different areas, right? The small and medium hits. But and lastly, it's in terms of going to consumerism and consumer demand, it was usually on our terms. Like, think about it. With even the data, the seminal piece of IOM, To Err Is Human, crashing at 747 every day, right? And Eric Topol will talk about the paternalistic side of medicine. The thing is, so we got to balance that, and if a consumer wants to choose based on their happiness, well, there's some philosophical questions about that given our history. So I just want to say that the last is this. When the ACA came out, and when I say it was based on our terms, all of a sudden we see a slam in our EDs because of, say, the Medicaid patients that didn't know that you get primary care, they use ED. My question is this, was that demand always there? Or did it create it? Meaning, so I think there's a question around, there's so much need in the community that we don't see. We're always restricted by our own resources, but I guarantee you, there's a big demand that we cannot satisfy, and using digital health and all these different techniques may help us to be able to take care of the larger populations.
I just have one liner. We have a philosophy of saying something for everyone and everything for someone, which means if you're looking at a population health for asthmatic, we have to have a least common denominator, at least tracking what their asthma control test ACT 5-item question is, and that we can measure for everyone, right? Through a text message, through other ways. But then there are people who are very not well controlled, who may actually go to the extent we're putting a smart inhaler in them to document it. So I think that way you can stratify and kind of tag your resources in the right manner, rather than offering Rolls Royce to everyone.
We just have 2 minutes for one last question.
Just quickly, how are you dealing with the potential of an additional layer of health inequity, right? Where you have education, health literacy, access to the technology, where we are creating a layer of access to the kind of thing, to these innovative ways of doing things. How are you dealing with it in your organization?
Here in the South Bronx, big question, Most people don't have computers at home, and income levels and the like. You'd be surprised how many of the homeless have these. So you can reach not 100%, not 90%, but a large number. We believe we can reach 90% of our patients electronically, one way or the other, texts, patient portals or something.
Yeah, I couldn't agree with more. New York City just came out a report. 92% people have cell phones, and 78% across New York City, including Bronx and Upper East Side, have smartphones. And they also have a Wi-Fi, which is within the city as well. So data plans, which used to be a problem for homeless population, is less of a problem now. And then if you augment this technology with IVR, interactive voice response, where you can still capture many S2H just by interactive bots asking this, you can extend to 94%. Of course, there'll always be 5, 10, 15% patients. But the thing is, you can, instead of you having manual people calling all the time, you are saving 90% of those effort. And that's humongous for us.
Then on the other hand, there are some rural areas that are pretty well without broadband coverage. I did some work up in southern Ohio earlier this year, and geographically, probably 10% of the area has coverage. Population-wise, it may be 75% with coverage, but some significant gaps. And when we hear about these rural health initiatives, that's really what it's about, is pushing the broadband nationwide. And it's a tremendous need.
Well, I think that there will be more dissemination of the technology. I think the problem people will find once they start trying to use telemedicine on a broader scale is that not every patient's broadband in their house is the same. And there are a fair number of technical issues on the patient side, whether it be, the cell phone or the iPad fell on the floor, or the broadband, the internet went down, or the broadband isn't so good, so reception isn't so good. So, yeah, I think there will be discrepancies in the use of these technologies, and they'll evolve over time as we all look at the social determinants of healthcare, which I think we haven't really touched on here, but I think are going to be very important at every level as an inclusionary part of our healthcare, irrespective of value-based purchasing or anything else.
My comment is touching on that, and I get to play with technology, but I don't at the same time. And so if you take two diabetics, a commercial and Medicaid, A1C is the same level, right? Diabetics, let's say 8 or 9. Just because the Medicaid patient has transportation problems, they're 1.2 times more expensive. They have a behavioral health issue, they're 3 times more expensive. And then if they have socioeconomic difficulty, they're 5 times more expensive. The question is, who's more diabetic? If they're the same. And I think there's going to be technology mix in that. There's going to be community partnerships in that. We're going to be pushing ourselves into very creative ways of expanding outside our 4 walls using tech, and also, say, just even from the social determinants of health side, of partnerships and collaborations.
And with that, a big thank you to the panel. I've enjoyed it, and I hope you've got, as the audience, I hope you've gotten some benefit from it.
Please thank Bill, Ivan, Ashish, Michael, and Peter for a fantastic opening keynote panel. The next